Hello, and welcome to this week's module on Foundations of Disaster Theory and Nursing Perspectives. This is the first of two lectures on major theoretical approaches in disaster research. Over the next hour or so, we're going to build the conceptual foundation you need as a doctoral level nursing scholar to critically engage with disaster science. This isn't just about knowing theories, it's about understanding how theory shapes every decision you make as a researcher. What you ask, how you design your study, what you see in your data, and ultimately what you recommend for policy and practice. So let's get started. By the end of today's lecture, you should be able to articulate why theoretical frameworks are essential in disaster research. Not optional, but foundational. Second, you should be able to compare and contrast at least three major theoretical perspectives: decision theory, economic frameworks like utility versus justice, and crisis theory models. Third, you should be able to apply the crisis conceptual nursing model to a disaster scenario, showing how nursing-specific theory guides assessment, planning, implementation, and evaluation across the disaster timeline. And fourth, critically evaluate how your choice of theory influences research questions, study designs, and interpretation. These objectives will carry through into Lecture 2 as well. Let's start with the fundamental question, why does theory matter? In disaster research, theory is your lens. It determines what you see and what you miss. Without an explicit theoretical framework, you're essentially collecting data in the dark. You might gather information, but you won't know what it means or how it connects to broader patterns. Theory helps you move from description to explanation, from observation to prediction, and from analysis to intervention. It also makes your work reproducible and allows other scholars to build on your findings. So when you read a disaster study, one of your first questions should be, what theory is guiding this work? And when you design your own research, you must be able to answer that question clearly. Disaster research draws from multiple disciplines, and each brings its own theoretical traditions. Today, we'll focus on four major categories. First, decision theory. How do individuals and organizations make choices under uncertainty and time pressure? Second, economic theory, specifically the tension between utility maximization and justice or equity. Third, crisis theory. How do individuals and systems respond psychologically and organizationally to acute disruptions? And fourth, nursing-specific models, particularly the crisis conceptual nursing model, which integrates clinical, public health, and systems perspectives. Each of these offers a different angle on the same phenomenon, and as doctoral students, you need to be fluent in all of them. It's not saying these are the only models. You can certainly go out and find articles with many other models, and you're welcome to use any of those or combine those, but that'll be later in the semester. Decision theory examines how people make choices when faced with risk, uncertainty, and incomplete information, conditions that define disasters. Classical decision theory assumes rational actors who weigh cost and benefits. But disaster research has shown us that real-world decision-making is far messier. People rely on heuristics and mental shortcuts. They're influenced by cognitive bias like availability bias, overestimating risks that are easy to recall, and optimism bias, revealing it won't happen to me. Emotions, social norms, and trust in authorities all shape decisions. For nursing researchers, this matters because patients and provider decisions during disasters, whether to evacuate, whether to seek care, and how to allocate scarce resources, are rarely purely rational. Your research design needs to account for this complexity. And this is very similar to what it is in everyday practice, as you practice now as a clinician. So we'll start with economic theory. Economic theory offers two competing frameworks for disaster response and resource allocation. The first is utility theory, which focuses on maximizing overall benefit and welfare. In a disaster, this might mean allocating resources to save the most lives or produce the greatest health outcomes. It's efficient, but it can be cold. It may sacrifice individuals or vulnerable groups for the greater good. I always use as an example children, unaccompanied minors, children that have gotten separated with their parents. They require a lot of resources. Surely there is no human response that says we can save all the adults if we just leave the children behind. And the same would be for people that may need the assistance of a wheelchair or may need a service animal. Anything that is outside the I'm 100% fully able requires, or anything requiring assistance requires extra resources. I don't know any part of humanity that says we don't save people who need a little extra assistance. The second framework is justice theory, which prioritizes fairness, equity, and the protection of vulnerable populations. Justice-oriented approaches ask who is at most risk, who has been historically marginalized. How do we ensure equitable access to resources and recovery? These two frameworks often conflict. As a researcher, you may need to recognize which framework is implicit in the policies and interventions you're studying, and be explicit about which one guides your own work. So let's make this a little bit concrete. During the COVID pandemic, vaccine disruption became a flashpoint for utility versus justice debates. A utility approach might prioritize vaccinating healthcare workers and the elderly first because they're at the highest risk of severe outcomes, maximizing life saved. A justice approach might prioritize communities of color, low-income populations, and essential workers who face disproportionate exposure and had less access to health care. Both are defensible, but they lead to different policies and different outcomes. As researchers, if you're evaluating a vaccine distribution program, your theoretical framework will shape your measure. It'll shape what you measure. Efficiency metrics versus equity metrics, and what you conclude about success and failure. Now let's turn to crisis theory, which focuses on psychological and social responses to acute disruption. One foundational model is Gerald Kaplan's three-stage crisis theory. Stage one is the pre-crisis or preparedness phase. It's baseline functioning with underlying levels of vulnerability and resilience. Stage two is the crisis event itself. So acute disruption, disorganization, and the need for immediate coping. And stage three is the post-crisis or recovery phase. Reorganization, adaptation, either a return to baseline or a new equilibrium. One way to think about this is pre-crisis. You have been alerted, and the news people have told you that there is a Category 4 hurricane 3 days off the shore. The crisis phase is the hurricane is making landfall, and the post-crisis phase is it has passed. Now we have to clean up the mess and help people regain their daily lives and get back to some sense of normal. The linear model is useful for organizing your thinking, but it's also been critiqued for being too simplistic. Real disasters don't always have clear boundaries between stages, and recovery isn't always linear. Still, Kaplan's model gives you a starting point for thinking about timing and intervention windows. A more sophisticated model is crisis in context theory, or CCT, which takes on an ecological perspective. CCT recognizes that crises don't happen in a vacuum. They're embedded in social, cultural, economic, and political context. The theory emphasizes that individual responses to crisis are shaped by pre-existing vulnerabilities, social support networks, cultural meanings of disasters, and structural inequalities. For nursing researchers, this is because it pushes you to look beyond individual level variables and examine the systems and structures that shape outcomes. If you're studying mental health after a hurricane, CCT would prompt you to ask, what were the pre-disaster social determinants of health? How did race, class, and geography shape exposure and recovery? This is where theory directly informs your research questions. One of the most widely used frameworks in disaster and injury prevention research is Hayden metrics, developed by William Hayden in the 1970s. The matrix is two-dimensional grid. The rows represent 3 phases: pre-event, event, and post-event, and the columns represent 4 factors: host, agent, vehicle, physical environment, and social environment. By filling in the cells, you can systematically identify risk factors and intervention points. So, for example, in a motor vehicle crash, the host is the driver, the agent is the vehicle, the physical environment is the road, and the social environment includes laws and norms. You can then ask what pre-event intervention reduces risk, what event phase factor minimizes harm, and what post-event actions improve outcomes. The matrix is simple but powerful and was originally used to address issues with traffic problems. It's been expanded from what it was to something that is slightly more complex. So here's a new graphic rendering of it with things that people have added to the original Hayden's matrix. So now you still see pre-event, event, and post-event, host, agent, physical, and social environment, but you also see effectiveness, cost, freedom, equity, stigmatization, preference, feasibility, and then other criteria. I like the way this has been expanded and the fact that researchers continue to think about it. Carol Runyon was the one that later added the third dimension to the Hayden's matrix, so the value criteria that I just showed you. The dimensions ask, how do we evaluate and prioritize interventions? The criteria include effectiveness. Does it work? Cost. Is it affordable? Freedom. Does it restrict individual liberty? Equity. Does it reduce or exacerbate disparities? Stigmatization. Does it harm vulnerable groups? Community preference. Do affected populations support it? And feasibility. Is it technologically, politically, and logistically possible? The third dimension transforms Hayden Matrix from a descriptive tool into a decision-making tool. As a researcher, you can use it to systematically compare interventions and make your value judgments explicit. We'll dive deeper into this in Lecture 2. Now let's turn to the nursing-specific framework, the Crisis Conceptual Nursing Model, or CCNM. This model was developed specifically for nursing practice and research in disaster context. It integrates crisis theory and nursing process, creating a framework that's both theoretically grounded and clinically actionable. The CCNM has 3 temporal stages: pre-crisis, crisis, and post-crisis, similar to Kaplan's model, but it overlays these with the 4 steps of the nursing process: assessment, planning, implementation, evaluation. This creates a matrix that guides nurses' actions at each stage of the disaster. So we're going to break it down in just a minute, but first I wanted to show you this graphic where I combined the SASS model and the crisis conceptual model. So you can see the pre-disaster, the disruption or the crisis, and the post-disaster. But what you can also then see is these cost-cutting phases of nursing. So the assessment, the planning, the intervention. At the same time, you have the factors of person, environment, nursing, and health. This is one way to think about nursing and to think about this model. So again, I took it and I adapted 2 models for a specific piece of work that I want to do. In the pre-crisis stage, the focus is on preparedness and prevention. Assessment involves identifying vulnerable populations, assessing community resources, and evaluating baseline health status. Planning includes developing disaster response plans, training staff, and stockpiling supplies. Implementation means conducting drills, building partnerships, and educating the public. And evaluation involves testing plans, identifying gaps, and refining protocols. For nursing researchers, this stage is where you study preparedness behaviors, risk communication, and the effectiveness of training programs. The key insights from CCNM is that nursing actions in the pre-crisis stage directly impact and shape outcomes during and after the crisis. During the crisis stage, the focus shifts to acute response and harm reduction. Assessment now involves rapid triage, identifying independent threats, and monitoring evolving conditions. Planning becomes dynamic. You're prioritizing interventions, allocating resources, and adapting to changing circumstances. Implementing includes delivering emergency care and coordinating with other responders and supporting affected populations. Evaluation in real-time is real-time monitoring, so monitoring patient outcomes, adjusting interventions, and documenting actions for after-action review. For researchers, this is most challenging stage to study because of ethical constraints, logistical barriers, and the chaotic nature of the environment. But it's also where nursing interventions have the most immediate impact. In the post-crisis stage, the focus is on recovery, rehabilitation, and resilience building. Assessment involves evaluating long-term health impacts, identifying ongoing needs, and assessing community recovery. Planning includes developing recovery programs and addressing mental health and rebuilding infrastructure. Implementation means delivering follow-up care, supporting community healing, and advocating for policy changes. Evaluation involves measuring recovery outcomes, identifying the lessons learned, and feeding findings back into pre-crisis preparedness. For nursing researchers, this stage offers rich opportunities to study long-term health trajectories, the effectiveness of recovery interventions, and the social determinants of resilience. So let's apply the CCNM to a real scenario. Imagine you're studying nursing response to a major hurricane. In the pre-crisis stage, you might assess hospital evacuation plans and staff training. During the crisis, you might observe triage decisions, resource allocations, and communication patterns. And in the post-crisis stage, you might evaluate mental health outcomes for both patients and nurses and the effectiveness of recovery programs. The CCNM gives you a structured way to organize your research questions, identify variables, and interpret findings. It also highlights the community of nursing care across disaster timelines. Nurses aren't just responders, they're partners, we're caregivers, and we're advocates throughout the process. Now, let's step back and connect theory to your research design. Your theoretical framework directly shapes your research question. If you're using decision theory, you might ask what factors influence evacuation decisions. If you're using justice theory, you might ask, do resource allocation policies exacerbate health disparities? And if you're using the CC&M, you might ask, how do nursing interventions in the pre-crisis stage affect patient outcomes during the crisis? Notice how each theory leads to different questions, different variables, and different study designs. This is why you can't skip the theory step. It's the foundation of everything that follows. Theory also shapes your study design. Decision theory might lead you to survey or experimental designs to test how information framing affects choices. Justice theory might lead you to comparative case study examining equity across different communities. The CC&M might lead you to a longitudinal cohort study tracking health outcomes across disaster stages. Your theory determines what you measure, when you measure it, who you sample, and how you analyze the data. And here's the key. If you don't make your theory explicit, reviewers and readers can't evaluate whether your design is appropriate and your conclusions are justified. So finally, theory shapes how you interpret your findings and what you recommend for policy. If your study is grounded in utility theory, you might recommend interventions that maximize overall outcomes. If it's grounded in justice theory, you might recommend interventions that prioritize vulnerable populations, even if they're less efficient. And if it's grounded in CC&M, you might recommend strengthening nursing roles across disaster stages. Your theory is your lens for making sense of data and translating findings into actions. And because different theories lead to different recommendations, you have an ethical obligation to be transparent about your theoretical commitments. So, in summary, let's try to make this a little bit of a bridge to lecture 2. So today we've established that theory is foundational to disaster research. It shapes what you ask, how you study it, and what you conclude. We've explored decision theory, economic frameworks of utility versus justice, crisis theory models including Kaplan, and crisis in context theory, the Hayden matrix, and its third dimension of value criteria, and the crisis conceptual nursing model and its integration of nursing process across disaster stages. In Lecture 2, we'll build on this foundation by diving deeper into advanced frameworks, specifically Chrysert's leadership theory, resilience, and vulnerability frameworks, and how to align theory with research design and policy relevance. See you in Lecture 2.